collaborating across disciplines can be challenging, especially when the disciplines are as different as social science and genomics. I'm Consuelo Wilkins, a physician and clinical researcher, and for the past 3 years, I've had an amazing time working with colleagues across multiple sites to find new ways to use precision medicine to tackle health disparities. And today I'm here with my esteemed colleagues.
Hector Myers, I'm a professor of medicine, health, and society.
And I'm Nancy Cox. I'm a human geneticist.
One of the things we've found is that to help bridge the gap, it's helpful to sit down and talk about these things. That's why we're doing this today, so you can hear some of the conversations that we've had about how we view things differently based on our perspectives and disciplines. So one of the first things I wanted to talk about is the use of the words like race and ethnicity and ancestry. So from the standpoint of social science and genetics, I imagine they mean very different things. So Hector, tell us what you think about when you hear the words race and ancestry. Ethnicity, go ahead. Yeah.
Right. One of the issues we have with the term race is that there isn't a consensus of opinion in the social sciences, at least, about what race is or isn't. For most of us, we are now thinking about race primarily as a social category that is socially constructed rather than an attribute that is biological. Some of us also argue that probably the more accurate way of thinking about race is that yes, it is socially constructed, but they're likely to be biological differences between the groups to some degree. But the problem is, are those biological differences inherent, or are those biological differences created by the social conditions that differentiate the different groups?
Mm-hmm. Nancy, what about you?
So I certainly think of ancestry as being a more informative term. For geneticists, it's a key thing that we need to take into account. People whose historical ancestry comes from different continental groups, they have different frequencies of DNA variants at many locations in the genome. And so we have to keep track of this historical ancestry to do the right things with the analysis of genetic data. That has some correlation to what people call race, but it's imperfect at best. And so I think geneticists, like social scientists, don't see race as a biological construct. Ancestry has history and demography and some allele frequency differences.
It's interesting that you are agreeing that race is a social construct. I would say that my experience has been different, that in many papers about genetics and genomics, the two terms race and ancestry are conflated, and people don't distinguish between the two. What do you think about that?
So I would say it's actually medicine that conflates them.
It's my fault.
And I think it's sort of it can be a shorthand because there are correlations between historical ancestry and the way race is currently used.
Right.
But it's not a very good. The race term just makes it more confusing, really.
And what about ethnicity? So, Hector, difference between race and ethnicity, this is coming up even more. What are your thoughts on that?
Yeah, well, the important distinction between race and ethnicity is that ethnicity is about culture. It's not really about race. So, and since all of us, everybody has ethnicity, has an ethnic or cultural identity, that variable captures much more of the information about, to some extent, history, but also the kind of belief system, behaviors, value systems, etc., that distinguishes different groups. It's important to notice in the way we use race is that when we use ethnicity, we are actually including race within it, so that ethnicity is different from race. It's not defined by race because races can be of any ethnicity, if you will.
Right. I'm really glad you're making that distinction. Historically, or at least in recent history in the United States, we have had a two-part race ethnicity question, and that the way that we ask that question allows us to only have two ethnicities. You're either Hispanic or you're not.
Right.
So what do you think? How should we, as we're trying to move this field forward, especially thinking about, precision medicine, should we do something differently? Have you thought any about that?
Yeah, I think we should recognize what that distinction is. It's a political distinction that ethnicity in terms of being Hispanic recognizes that Hispanics can be of any race. But the unfortunate other side of the coin implies that somehow, unless you're Hispanic, you don't have an ethnicity, which is nonsense. You don't have a culture, which is nonsense. So I think what we have to do is to separate the politics and the political ways of talking about these terms and place it back in science. Everybody has an ethnicity, and one could argue everybody has a race, whatever that means, if you will.
So related to this, Nancy, you obviously are very, very familiar with the large database that we have here, BioView, that's electronic health records connected to DNA, and within that, this fantastic resource, how we identify race and to whatever degree we're capturing ethnicity. We're not sure even how it's reported. Sometimes is it reported by the person? Is it reported by the person who's in front of them? So
well, historically, that would often have been filled in by someone at intake who would look at you and decide what they thought your race and ethnicity was. They might or might not ask you. I think more recent, and sometimes it might even have been filled in by the physicians. It would depend on.
And we got it wrong.
I presume now that at least sometimes it is a self-report that people are actually asking how you would like to be classified, or you're filling that out as part of an intake form. But it is a poor proxy for the kinds of information we actually need to do the right things in medicine.
So switching gears just a little bit. So we're part of the center and we're focused on, health disparities. And of course, some people would say if we want to tackle health disparities, precision medicine isn't the way to do it. And others are more hopeful. But if we're just thinking from the standpoint of addressing health disparities, given your disciplines, Nancy, we'll start with you. How would you approach health disparities as a geneticist?
So I think one of the ways that we've tried to tackle this problem is to recognize that most of what we measure as health disparities are likely to be a consequence of sociodemographic factors, access to healthcare, where you live and how polluted that environment is, how close you live to grocery stores, how easy it is to partake in exercise safely. Separately, we recognize that the DNA we've all inherited has there is a historical context to it. And anyone whose recent ancestry includes, for example, living in high pathogen environments may carry adaptations to those environments that when you live in those environments are a very good thing. But when you don't, may have an effect on your health in things that we see as health disparities. So some component to some things that we see as a health disparity may come from genetic factors that have different frequencies in different parts of the world. And so when you derive ancestry from a part of the world that has a high pathogen burden, that may place you at risk for diseases, certain kinds of diseases.
Maybe nuance it a little bit. So we're talking about high pathogens, but we're also, hear about environmental influence, like stress and epigenetics and
Absolutely. And so what we try to do is to look for the genetic factors by correcting as much as we can for the ancestral differences in allele frequencies, but then separately trying to look for the non-genetic factors by correcting for the genetic factors. So we can try to highlight diseases, conditions that can't be explained by genetic differences, must be attributable to non-genetic factors. And some of those factors can be, as you say, a response to stress in your environment, but some could be direct exposures to environmental toxins because of where you live or what you do for a living. Some of those could be factors related to diet that may correlate to something like ethnicity, to the food and the culture that you choose to live in and identify with. So the non-genetic part includes many different kinds of things that could contribute to risk of disease.
Hector, how do you, as a social scientist, approach disparities?
Right. Let's start first by talking about perspectives. Okay. In the social and behavioral sciences, we take a social ecological perspective on behavior, health outcomes, etc. We tend to look at the context in which people function, which is part of what you said, and ask the question, what is it about the setting in which they are functioning that contributes to any health outcomes that we see? So essentially, we're talking somewhat of the same thing. The only difference is we don't usually talk about genetics, although that's a secondary variable because it's internal to the person. What we tend to do is try to place that person in the context and then provide very precise observations, precise measurements of all of those contextual variables to see how they impact on the person and how the person's individual characteristics impact on their response to the environment. So it's an interaction of person in context perspective. So we would emphasize then in terms of trying to answer questions about health disparities to see, are there consistencies in terms of the context in which different ethnic groups are primarily functioning that may account for the group differences that we see. And it's not just in terms of risks, it's also in terms of resiliences as well. Because not everybody, for example, who is poor is oppressed by their poverty. Some people will function perfectly fine despite the poverty, or they may actually grow from having to struggle with the limitations of poverty and become far more resilient.
I do want to come back to socioeconomic status and also political pieces and the overlay with some of this, obviously. But as a clinical researcher who I feel privileged to be able to work with people who are social scientists and geneticists and others who do more translational science. But from my perspective, what I see sometimes as a crossroads, and Hector, you said you're being precise. You're being precise in your measurements. Is that often because we're using different kinds of measures, each thinks the other is less precise in some way.
Yeah, and we are. That's true.
And I would also say, as part of that, the numbers of people seem to be a big challenge for the different disciplines. So I see on the social science side the importance of diving deep and knowing, everything about perhaps fewer people, and on sometimes the genomic side, this large, vast amount of data being used, and neither discipline really sees both see that as not quite the right way to do it.
The level of precision is far greater than the level of precision in the social and behavioral sciences. We rely pretty heavily on asking people's questions and then getting their answers from it. And we all recognize there's noise there. There's a certain amount of other response biases and issues like that. But what I'm talking about precision is I'm saying that we are not asking questions, simplistic questions about context, or trying to use estimates of context. We actually try to measure the context as best we can. So the social behavioral sciences have certain strengths that I think can benefit our analysis of what is causing these health disparities, because we are actually not just simply thinking about what's inside the person. We are also looking at what's outside the person at different levels. So we pay attention to not only the individual, but his or her family, his or her social network, the community, the point you mentioned, the characteristics of the community. But we also go to the other level and ask questions about social structures. Access to quality healthcare, for example, that is not an individual variable. That's a structural variable. And consequently, we have to struggle then with how do you draw conclusions by bringing into the analysis these structural processes, and how precise can we measure those, if you will.
But however precise, social scientists do measure them. Geneticists rarely can access any of that data.
Right.
So for the most part, geneticists use data that are collected in the context of either medical care, so the big bank at Vanderbilt is linked to electronic health records, and so that is basically all of the information that we have about the patients. A lot of information from a healthcare perspective, but it's much lighter on all of the information that is routinely collected by social scientists. It's data we would certainly love to have on everyone, but it's expensive and time consuming to collect. And it is true that now genetic studies are being conducted routinely and reported on to be working in collaborations to think about how best to do that, because we're clear on how important it is to do that.
So I want to get to my point about the socioeconomic status. So we've been talking mostly about race, ethnicity, and in the United States in particular, for most racial and ethnic minorities, they're experiencing other social disadvantages, especially from socioeconomic standpoint. So as for your disciplines, and I want to challenge Nancy to think not just how she thinks, but how other geneticists think. No offense to either you or your colleagues, but just in my conversations with you, I think you are more thoughtful, perhaps, than some others that I have spoken with, and considering what the other social contexts are as it relates to health. But thinking about socioeconomic status, what do you think the impact of lower socioeconomic status, or limited resources, social disadvantage, just other than race or ethnicity, how is that impacting health, and how should we be considering that from precision medicine?
What you find is that SES is patterned by race. That's a term he uses. And what he means by that is that SES means slightly different things in terms of its impact on people's lives very much as a function of what racial group are you talking about. However, the magnitude of the benefit for upward mobility is measurably different for whites than it is for blacks and for other persons of color. That race qualifies what socioeconomic status is. So when you actually combine being of a lower SES and a person of color, what you get is a much more damaging consequences that result from that. And it's literally a damage to the health trajectory. It's not just the differences at any moment in time. This is people are on different health trajectories, is what we're seeing right now, which would help account for why the persistence of the differences, because we know that there are upward mobility changes that happen in society in a lot of different groups, but that has very little impact on overall health disparities. Yeah. Health disparities haven't changed.
Right. I want to tweak that question a little bit for you, Nancy. So for genetics and genomics, I think certainly you can answer the first question as far as the what the impact is on health disparities. But I think a lot of concern for socioeconomic status is about availability of the potential outcomes and discoveries that will limit and perhaps widen disparities. But just tell us a little bit about what you think about as it relates to.
Two things that I think we need to discuss frankly now is that because there is some confound in the U.S., not necessarily in other places, but certainly in the U.S., between SES and proportion of minority ancestry. We've probably overestimated the genetic contribution to some health disparities that may have some genetic component, but because of the confound, it's easy to overestimate the contribution.
Can you give us an example?
Yes. So we certainly have, we know, for example, from studies of Hispanics in Texas, that there really wasn't any association between the proportion of Native American ancestry and their risk of diabetes in a county on the border between Texas and Mexico. But in Mexico City, there was a strong relationship between the proportion of Native American ancestry and the risk of developing type 2 diabetes. Now, that turns out in hindsight to be driven almost certainly by socioeconomic status, which is highly correlated to the proportion of European or Native American ancestry in many places. But in the county in Texas where these studies were done, it was virtually all Mexican American, 98% Mexican American, with uniformly low socioeconomic status. So there was no variability in socioeconomic status. And because of that, we saw no association to ancestry. There was a pure ancestry with no variability in socioeconomic status and no relationship between proportion of Native American ancestry and diabetes risk. But you could see it in the Mexico City populations. So we must do better at capturing the non-genetic factors that can co-vary with the ancestry covariates that we use in our studies. And that's why we worked so hard at Vanderbilt to capture some measures of social deprivation, socioeconomic status in our health record, because it can be so confounded with the very things that we're trying to disentangle and study. And there are places where it's not. And that's, it is a great pity how confounded it is. And we should be working to disentangle it.
Yeah. So I want to switch and sort of move into maybe our final piece of the discussion, which is let's solve a problem. Okay. So first, I want each of you to just briefly say how you would approach this problem if you were working with other people who are in your field. And then I want us to spend some time talking about how we might work to solve it together. So for some populations, especially in this country, Black women and their babies have worse outcomes. So infant mortality is higher, substantially higher for Black, African American, women of African descent who live in the United States. So, Hector, how would you, if you're working, with others in your department, address that? What kinds of things would you be considering? What would be your approach there?
Well, a couple of things. First, I think we need to spend some time talking about how we classify people into groups, right? Because yes, it's true that there's a disproportionate burden of negative health outcomes for Black women. But when you look among Black women and take into account whether or not they are U.S. born in Africa and coming as immigrants, or immigrants from the Caribbean, you don't see that same birth outcome pattern. So one obvious question is why? And people have speculated about a number of things. Number one, with people from Africa, we may be looking at what is often called the healthy immigrant. The people who migrate are the ones who have the drive, and they're often coming from better social situations at home than the typical African American here. From the Caribbean, you get a similar type of phenomenon, and that is, again, it could be a phenomenon of the healthy immigrant. But there may be other issues. If you look within the groups, I guess my point is we need to begin to do a much more sophisticated job of understanding the within group variability.
And so you'd be thinking about, what contextual information, how these women are different across their circumstances, and including their, how their lives, socioeconomic status, where they were born, et cetera. So your approach diving deep, getting as much contextual information as you can. Nancy, how about you? You're working with other geneticists. What's your take on it?
I think, the obvious thing, it's, you're a carpenter, you got a hammer. Right. So we'd be looking for the genetic factors that are more common in populations of recent African ancestry, regardless of whether they're born in the U.S. or born in Africa or born in the Caribbean. The proportion of African ancestry would be trying to take into account, but looking for particular variants more commonly observed in the women with the worst outcomes than in women who have better outcomes. I think, so from a purely genetic perspective, that's the way the study would be done. I think it would be better to have the deeper perspectives, to include information on not just socioeconomic status, but as Hector pointed out, country of origin. There's some really interesting biology that we have recognized in immigration studies. So Indians born on the Indian subcontinent who moved to the UK, after they were 3 years old, so lived the first 3 years in India and then went to the UK, have essentially the rates of type 1 diabetes that is present on the Indian subcontinent, which is very low. Indian children who were born in the UK, so like their parents migrated while the mother was pregnant, so born in the UK, essentially have the rates of type 1 diabetes that people in the UK have. And in the first 3 years, their degree of risk depends on how much of their early life is spent in India as opposed to the UK.
Mhm.
And some part of that may be the hygiene hypothesis is consistent with those kinds of observations, but so are certain kinds of
Mhm.
more specific exposures.
Mhm.
And so Hector's point about the data that can be emerging on where people come from and when.
Mhm.
So people who were born in Africa and came here may have been exposed to high pathogen environments early that set their immune systems on a different course. Change maybe the pregnancy risk outcomes. That, if to the extent that we can learn from that and take it into account, there might be more measures that we could collect that would help disentangle both the genetic, the exposure biology, and the things that are different for African American women in U.S. societies.
So Nancy, you're going to take your cohort, you're going to identify people in BioView, women who've had worse outcomes, and then we're going to work with Hector to find ways to better deeper get deeper contextual characterization of the women. What's their social setting? Where, how long have they been in the country? Their socioeconomic status, and Hector, you're going to tell us about some unique ways of doing that. Are there existing tools, community surveys, other data that we might bring to the table for this?
Yeah. I'd like to answer that question a little differently.
Okay.
Because as I was listening to you, it dawned on me that one of the ways going forward actually would require us to design studies with both disciplines present. Because, for example, the point of how long they've been to the U.S. Well, how long they've been to the U.S. is important because one of the things we know that happens with immigrants is the longer they live in the U.S., the more their health status begins to look like the folks in the U.S.
Yeah.
But what we don't know is, but what about their living situation in their home country?
Mm-hmm.
We assume that all of these immigrants, we either assume that they're all very poor people or we assume that they're not.
Mm-hmm.
But we don't know much about the specifics.
Right.
And there's some really interesting data coming out now about early childhood experiences and predicting risk.
Mm-hmm.
Now, we don't have the mechanisms entirely worked out. So this is an opportunity now for bringing geneticists and other biological scientists in collaboration with social and behavioral scientists to each of us coming together to measure the variables that matter as we think they matter. And then we can test it directly.
But yes, so he's exactly right. There's some new machine learning kinds of approaches called transfer learning. But the requirement for that is that you have some data where you measure a lot of things that you think, some that you think might matter, but you just measure everything you can. And those can't be very big data sets because you're going very, very deep.
Right.
But once you have those data sets, you can use all of that information to try to learn the things that allow you to predict in other data sets the things that do matter. So things that we can't ever measure directly inside BioView, we might be able to build proxies for, predictors for, in a data set like that, where, for example, we may never be able to know where someone was born, but we might be able to find proxies for the likelihood they were born outside the U.S. versus not, in patterns of disease that they report having had, or even aspects of diet that may come up. So
I hate to cut us off, I feel like we could keep going
Oh,
for a
yeah.
long time here.
For a week or so.
That's sort of the point of the
That's
project.
the point.
Exactly.
That's the point. That's the
exact
point.
point.
Well, this has been a fantastic discussion, and I think perhaps the most important piece is that you ended on we should be starting to design the studies together.
Yes, I think so.
And I'm hoping that we'll have even more opportunities to do that. So
Just that.
I hope that others will find this helpful and interesting, and I look
Yes.
forward to another opportunity to sit with both of you.
Yes.